Okay, well, thank you everybody for coming. Landon is a Wisconsin native, having graduated from the University of Wisconsin with a degree in microbiology. He gained research experience working as a research assistant at the University of Wisconsin Health System in the Otolaryngology Head and Neck Surgery Department, where he managed over 15 quality improvement projects. Since joining KCU, he has helped coordinate Med Student for a Day, teach and tutor first-year students in anatomy lab, and was a volunteer for the KCUMB Community Health Clinic. Landon is currently a third-year medical student, completing his clinical years in Denver, Colorado, where he recently presented Efficacy of Barbed Suture and its relation to postoperative infection at Centura Health. He is also currently involved in the American College of Surgeons National COVID-19 Registry study. He will be presenting his case report today that's titled A Rare Case of Spontaneous Thrombosis of the Aortic Valve Associated with Nasal Cocaine Abuse, which has been submitted for publication. Landon, after completing his clinical years in Denver, will be applying for residency in general surgery this fall, and he hopes to fellow in trauma and acute care surgery after his surgical training. Landon, I will turn it over to you.
Okay, thank you so much for the introduction. Let me share my screen. And do you all see my screen currently?
Yes.
Good to go? And you all see my mouse?
Yes.
Okay, awesome. Well, thank you for the introduction again. My name is Landon. I am a third year. And today I am presenting a rare case report on spontaneous thrombosis of the aortic valve associated with nasal cocaine abuse. This was a really interesting thing that I got to be a part of, and I'm really glad I get to share it with you guys today. So I wanted to start off with just the general presentations to get an idea of what we were looking at. So we had a gentleman that's in a mountain region ER nearby of where I'm living. In this mountain region ER, he presented with chest pain. Essentially, he had chest pain that was uncomfortable, and he was in his car driving and decided, I want to go to the ER. He noted that it was sudden onset chest pain radiating to the left, shoulder blade, jaw, and he had dyspnea while he was driving. The big kicker for this, other than the classic signs that you will see on your right, or on the picture on the right here, is that he said it was identical to the last time he had chest pain, which coincidentally was 5 years prior, and that required a stent in a branch called the diagonal branch. So from there, we got a past medical history on him, and he had coronary artery disease, hypertension, cocaine abuse, a pack year history of 30 for smoking, type 2 diabetes, and then sleep apnea. To be noted is the cocaine abuse. So the cocaine abuse, he used 36 hours prior to admission, and he had a multitude of chronic use disorder of cocaine, and he had been using for many years, despite people telling him not to. Initial workup, we thought immediately, if we are looking for a heart attack, because he has classic signs and symptoms of a heart attack, we decided to immediately put him on the mnemonic Monobash, which is used in inpatient cardiology. Monobash stands for morphine, oxygen, nitro, aspirin, beta blockers, ACE inhibitors, statins, and heparin. So we did all that, which is the classic use of someone in an acute heart attack. And we got some labs on him. And so the labs on him at this mountain ER were pretty unremarkable, except for what I've gotten in red here, and I'll explain that. Number one, his max heart rate was 173 over 111, which was higher than we would expect. Otherwise, his vital signs are pretty much normal. His lab data in association with the hematocrit, I just wanted to talk about here in green, because living in Denver, we have a higher amount of, we have less oxygen here. So if we have less oxygen, we're going to be having higher amounts of erythropoietin from our kidneys. And we generally here in Colorado are very dehydrated. So this is a relatively normal finding in most patients I see here in Denver. You look at the very bottom, we have our troponins, and this was another indication that we wanted to get him to the Cath Lab. He presented with a 0.068, and he ended up peaking at 4.316. Most people know, but I will say it for here, that troponin is only released in the heart. And so if there is a certain amount of damage in the heart, that is how we know it's heart specific. So we had indication that this guy was having a heart attack of some sort. Last thing I'll mention is his second to last thing. He has type 2 diabetes, so this was uncommon, and he did not take medication, although we prescribed him medication years prior. As for medications here, these are what he was on at the time or he was supposed to be taking. My attending told me that this gentleman had many medications he was supposed to take, but his only preferred medication was the cocaine that he was using. So he had neglected to take any medication. And this prasugrel here was prescribed for him the day of, because prasugrel is used by cardiologists. It's a kind of a heparin kind of like substance that is used for making sure that there is not going to be any coagulation going on prior to surgery or prior to Cath Lab. So with all this in mind, we decided to take him to the Cath Lab. So I wanted to first mention that the Cath Lab standard protocol is 90 minutes door to balloon, where we have and it's actually really cool here because Dr. J taught me cardiology, so it's cool being able to do a little talk with him in here. But Dr. J told us, and I have remembered, that it's usually 90 minutes from door to balloon, or from 90 minutes from presentation to Cath Lab. And if after that point it does not work, or you're not able to get there because you're in a mountainous region, you should get TPA. In clinical practice, I asked my physician this, and he said most people actually go longer than 120 minutes still. And it depends on how comfortable the cardiologist is. So my cardiologist, this was more than 90 minutes, but he elected to do a Cath Lab because of this guy's clinical picture and his previous history of stenting. So I wanted to tell a little bit about the Cath Lab because not many people have been in a Cath Lab, or it's been a long time since they've viewed one. A Cath Lab here we see is there's techs here, and there's a assistant, and then we have the lead cardiologist here that is sticking a catheter in a fully awake patient that has been that's sedated, moderately sedated, and they are sticking a catheter along with a separate valve that has radioactive iodine. And so this iodine is shot in at bursts in order to visualize the heart. The heart in itself is visualized with this C-arm, and this C-arm is essentially looks like a claw machine, but it's facing the patient, and the head goes between the C, and it's rotating at a certain axis. Each different movement that cardiologist could say, I want a RAO, I want a LAO, I want all these different acronyms that essentially mean I want this camera in a different position. And so this guy here, the tech, will move that for the cardiologist to be able to view. At the same time, he's injecting dye, and he's looking at the heart in different spots. And I'll go over that in place. So I think that is what I wanted to talk about that. So now we get to stents. And so the classic thing that most people stent, like the terminology stent is thrown around in the public all the time. I actually did not know what the stenting procedure is, and I thought it was very interesting to learn. When you stick a balloon catheter or a catheter into a vessel that has atherosclerotic disease, as shown in this picture on the left, I thought originally that we can scrape off the stuff from this walls here, but actually ballooning is much more common. And ballooning, all it does is we are blowing up the balloon and leaving this guard fence at the edge. And so essentially all we're doing is just shoving the crackers under the kitchen fridge, and we are just making sure that we're trying to prevent anything from getting bigger, but we're just pretty much shoving it against the wall and smushing it and making sure nothing happens like that again through medication and pharmacologic therapy. So that was really interesting to me. Another thing I should mention is I asked my attending yesterday if there were any other options besides balloon. He prefers balloon, and most cardiologists prefer balloon, but there is something called an atheroatherectomy, which is essentially you have your artery, and it is blocked by the atheroma. And so if the block is by an atheroma and you have a heart attack, you can go in with a small catheter that has a rotatory blade. And this rotatory blade can open up the closed artery and give you reperfusion, which is what we want. And then after that, they would do a balloon angioplasty and do what we see here. So that's the general consensus of what's going on. So that's what I learned for balloon angioplasty. So now next thing the cardiologist will try to pimp you on will say, hey, what's the difference between a left heart cath and a right heart cath? A left heart cath is essentially we're going through the arterial supply to get to the heart. We'll either go through the radial artery or the femoral artery, and we will advance the catheter all the way until we get to the ascending aorta or the thoracic aorta here. And then we will, there are two exit points of the thoracic aorta, the right coronary artery and the left coronary artery. By doing that, we are able to visualize all of the arterial flow in the right heart and left heart, all that stuff, to be able to see how efficient and if there are any blockages, if there's slow flow, if there's anything. So that's the general consensus. I put this in green because this is great board fodder and it's just general good knowledge, is that you can't, because we have radioiodine that is given to patients, you really can't give that iodine to someone who has chronic kidney disease or acute kidney injury, primarily because you can induce something called contrast-induced nephropathy, which is essentially your kidneys fail from iodine exposure. This is really important, but often it's overlooked by cardiologists because cardiologists think that they can just kind of push the envelope a little bit. And they can, what's more important is getting the heart fixed rather than the kidney fixed, because the heart is more likely to kill you than the kidney. And it's actually a really big ethical dilemma of you can cause dialysis on someone, but they're alive. And it's a big issue, but for the most part, cardiologists stretch the envelope and they think it's okay. And I have not really seen too much contrast-induced nephropathy from that, but I just wanted to mention it. On to right heart cath. Right heart cath is essentially this picture on the right here. All we're doing is we are taking now, instead of the arterial supply, we're going through the veins. And so this is either done through the internal jugular vein or the femoral vein, or even if someone is young and has really big veins, radial or something like that, or brachial. It's advanced up just similarly, and this time it's shoved through the superior vena cava. And when we go through the superior vena cava, we are looking solely at the pressures of the right heart. And this is done usually for pulmonary hypertension, valvular disease, heart failure, stuff like that we want to measure a demonstrable effect of the pressures in the system. You're not looking at the arteries, you're purely looking at how the pressures look, and theoretically, you'll know how the lungs are functioning because of the pulmonary artery here. As we go on here, so if you can't tell already, my doctor said he wanted to do a left heart cath because we thought he had a heart attack, and heart attacks are blockages in arteries. So I'm showing you now, this is we're looking at the right side of the right coronary artery, and here is the aorta. So the aorta, he put this catheter down through the aorta, and he has managed to jimmy the catheter into the right coronary artery and is injecting dye. And so this picture shows the dye that I took a picture of. So really, this is not impressive. This is a physiologically normal looking right coronary artery. I just wanted to point out some anatomy. You have the RCA, the right coronary artery, and eventually it splits off into the pulmonary or posterior descending artery. And then we have here, I put mild stenotic segment, because if you look really close, you can see there is narrowing of this stenotic segment right here, of this segment of the RCA. This happens in a lot of people. It happens with atherosclerosis. It happens in just general anatomy. People have collateral branches. There are a lot of things that cover, and actually you can see collateral branches right here that can override this area. So take home point, this looks like nothing. Then we go to the left heart picture. The left heart here we have, this is the left circumflex. We're looking at the left anterior oblique view, because here's the LAD, or as Dr. Olinger would call it, the anterior interventricular artery, but most clinicians say LAD, or the widowmaker. Here's the left circumflex, and it has a nice marginal artery, or ramus, as some cardiologists will say. And again, we have a mild stenotic segment here, but nothing to write home about. The LAD looks fine. The left circumflex looks fine. Diagonals look fine. We really didn't see much. We got finally a pure look at the left anterior descending artery. Again, normal everywhere, but I did want to show this. This is a variant of something that most people don't get to see. It's something called the intramyocardial segment, where the artery dives into the cardiac muscle. So when it dives in the cardiac muscle and the heart contracts, it'll squish that blood vessel. And so it actually looks like it's blocked, but it's not. So after we have diastole and the blood flow is there, you'll see it reperfuse just nicely. So this is normal. It doesn't cause any chest pain. It's totally a normal variant. And my doctor told me that as well. So for one, I got this picture because he clearly has never gotten an echocardiogram, because they're really annoying to deal with. And this is just a very humorous thing in my eyes. But so from there, we get a catheterization. So after the catheterization is done, we think, okay, we don't know what's going on. During the procedure, he said, I feel better. I don't have any pain anymore. But we didn't do anything. We didn't put any stents in him. We didn't balloon him. We didn't do anything. We just looked and said, it looks fine. So we decided to do an echocardiogram. Now, normally, if you have a kind of a clinician's brain going right now, a echocardiogram is usually done prior to the catheterization if it is in an elective scenario. Well, my doctor wanted to do this immediately because he had the classic clinical picture of doing a cath because of a heart attack. So risk-benefit wise, if we delay his PCI or cardiac intervention, he could die on the table if it is something demonstrable. I did neglect to tell you guys that we did have an EKG, multiple EKGs, and the EKGs showed ST elevations in multiple leads. That was significant for, it was similar in change to his last heart attack. But because he was at the ER in the mountain range ER, I was not able to get the EKG to show it to you guys. But trust my word for it, it showed signs of an ST, like an ST elevation heart attack. So prior to echo, that's what we would do, but we decided to only do this. So I went back to his room, and my doctor and I told him, we don't know what's up with your heart, but we want you to continue taking your aspirin and your Plavix for life, because theoretically you have maybe some, we thought, vasospastic angina. Cocaine is a very a hyper like vasoconstrictive drug, and I will go over that in the physiology later. But the classic is someone that comes with chest pain that has used cocaine previously in the past 24 hours or so, and that's vasospastic angina. So we thought, it's probably that. We'll hang our head on that, but we're going to order an echo just to be safe. So we got an echo on him, and here's what we see in the echo. Here is the aortic valve. We're looking from the aorta top down, and we see this massive mass, this huge mass that is almost enveloping half of the aorta. So you can't appreciate it because it is obviously not a video, but this was hypermobile. It looked kind of like fluidy. It looked as if it was just rolling around and tumbling in this area. My doctor was very concerned, as he should be, and this was a very unique find. As we go into the other views of the heart, I managed to add the left atrium, left ventricle aorta, because this is pretty hard to wrap your brain around, but trust my word for it. Here's the aorta, here's the aortic valves. And here we have that again, that giant mass that is near the right coronary artery opening and the part of the right side of the aorta. So this was concerning, because if you recall what we did literally an hour ago, from this point, we had shoved a catheter into his right coronary artery and left coronary artery, which could have easily, this could have easily dislodged part of this, gone up to his brain and killed him instantly. So we are stunned that this happened on our watch, and it did not, thankfully he survived. So this was, my doctor, I remember, he was shaking and was sweating because this never happened to him. And he said that this was, this guy scathed death. It was very, he was very concerned. So then we decided to get a CT of this guy. And here you can see this hyperdense mass here is elongating up the thoracic aorta. And it's a little bit better to look at on this view. And this really shows the gravity of the size of this. The aorta itself is a high pressured system, and it's the highest pressured artery in our body. And so we just were shocked to see a mass in the aorta that looked thrombin in nature, or thrombus in nature. And here's another view as well. And it's again, kind of showing that in this tiny, or this big mass enveloping almost a third of the aorta. So we immediately consulted cardiothoracic surgery, and cardiothoracic surgery moved him to our central location here in Denver. So the general process of it was they did a sternotomy, which is a open heart surgery. They isolated it through cardiopulmonary bypass, and then they transected the aorta, i.e. they cut the aorta in half, and we're looking at the mass to remove it. According to the cardiothoracic surgeon, it appeared to be a thrombus. They sent it for pathology and confirmed that it was definitely not a myxoma or a fibroblastoma in nature. So those are the two big things you worry about other than the thrombus. They did confirm it was definitely a thrombus. The doctor noted that it was pedunculated at the base, and it was the valve near the nadir of the annulus, or the opening of the right coronary artery. So I have two pictures that I have here of what it kind of looks like. So it found to be here. This is like the big thrombus. And then what was interesting is the cardiothoracic surgeon was flushing and trying to get everything out of these arteries. And this little guy popped out. This is a 5 millimeter thrombus that's found in the os of the right coronary artery. So although this guy had no symptoms, for some reason he had a large thrombus that was now at the opening of the right coronary os, or right coronary artery, or the os of the coronary artery. So this was very interesting because, again, we were manipulating this area with a catheter. So we don't know how this presented. Most likely, this was a portion of the mass that then somehow, instead of going up to his brain, managed to dislodge and go into the right coronary artery. So we are very thankful that it did not go up to his brain. And cardiothoracic surgery here was done, and here is the mass. So this was very fibrinous in nature. It was thick, but it was also thrombin-like in nature. I can't speak for the cardiothoracic surgeon because I have never seen something like this before, but trust my word for it, he said this was definitely a thrombus. And here's a little 5 millimeter thrombus that was found at the opening of the right coronary artery, or the right coronary os. So from here, we get to just the general discussion of the case. Afterwards, this guy, we took him, or he went to the ICU, cardiac ICU, and we did a hematology consult on him, and we gave him medication that he was supposed to take, and we sent him on his way, and apparently he's doing well now, but he was lost to follow-up, and I can't confirm that he is doing any of his medications, or he has stopped using cocaine. But from now, this is what I wanted to talk about, is the physiology behind it. So I wanted to tell about my case report title in general. Spontaneous thrombosis of the native aortic valve is kind of a very different way of looking at things. A spontaneous thrombosis, in my eyes and in cardiology's eyes, is primary. It's not coming from anywhere else. It's established right there and only there. Native aortic valve is the patient's original valve. It's not mechanical or replaced. So we are looking at someone's unique own valve that somehow had a thrombus right there for him. Based on what I've looked at on PubMed and different papers, there's only been 13 cases published like this, and 3 of which had to do with cocaine. So this is a very rare, if not almost impossible thing to happen. So in the aorta itself, we have a multitude of things that can form. Most likely, although it's rare, the most common is still a thrombus in the aorta. Usually it's from something else happening there. It's like secondary, but primary-wise, a primary thrombus is very rare. Then we get primary tumors like a fibroblastoma, angiosarcoma, leiomyosarcoma, and unfortunately the feared thought of metastasis from another area. Like I said earlier in my presentation, the aorta itself has the highest pressure in the body, so it doesn't theoretically make sense for something to stay there. If you think about a thrombus, the likelihood, and Dr. Singh taught us this, is the likelihood that a thrombus is in a form is when you have I don't remember the triad, but it's venous stasis, hypercoagulability, venous stasis, and endothelial dysfunction, some triad. Anyways, so that triad is where we think about things happening. Hypokinesis, places that have like the left atrial appendage, little outpouchings that can have thrombus. But in the aorta, it doesn't make sense for something so high powered to be able to have something grow and for a long time. So that was the thought process, along with, and here's a little fact, incidence of an aortic thrombus was 0.45% in a study of 10,000 autopsies that were done. So it's relatively rare. Okay, so now we talk about spontaneous thrombosis in general. So here's the bread and butter of this is what are the main causes of a thrombosis of the aorta? Number one, prior cardiac catheterization. And we're not talking about immediate, well, it can happen in a prior cardiac catheterization that is immediate. However, due to the size of this thrombus that we saw, there's no way it could be, because this has definitely been, due to its fibrinous nature and its large state, it's huge. And so do we think it happened 6 years ago when he had his last one? Probably not, but because that just wouldn't make sense with timing on that big. It could happen, but we have no idea. We can't look back in the past on that. Cardiac surgery, same thing. When you're causing endothelial dysfunction, you create a nidus of an area to be able to grow. So that's another option. Valvular disorders, my doctor called it burned out infective endocarditis, where endocarditis, when it's done its job, it now sits there, and then it's, again, nidus for stuff to grow on. Hypercoagulable states, antiphospholipid antibody syndrome, hypereosinophilic syndrome, and protein C and S deficiencies. These three are well known and studied as hypercoagulable in nature. And unfortunately, they require a hematology consult. And we got one, and it was lost to follow-up. So we have no idea if this gentleman has this. But like I said, arrhythmias, hypokinesis from cardiomyopathies, places that have less flow are more likely to have thrombus. And then that brings us to cocaine abuse. So cocaine abuse has a large variety of things and what it causes. And I didn't know that cocaine caused this much. I only knew it causes vessel wall injury and where's the other one? Like ischemia. But it has a multitude of things that are going through. I'm going to focus mostly on prothrombotic state, but there's a large list of things that can happen from cocaine that I was not aware of. So as we get to the cocaine abuse in the cardiovascular system, here's the classic board question of coronary vasoconstriction, where we have the vasospastic angina. This is because you have increased endothelium 1 levels and alpha receptor stimulation. So if you recall, cocaine is an alpha-1 agonist that causes vasoconstriction. So why this is usually used in the board concept is, well, can we give someone a beta blocker to lower their hypertension? No, because that's unopposed alpha, and so it'll make it even worse, and they could die on the table. So that's why you never give a propranolol to someone who, or metoprolol to someone who has just used cocaine and is now presented with hypertension. So there's other things that are classic with cocaine. We have increased myocardial oxygen demand. We have hypertension. We got cardiomyopathy, which this is the one that's most known. Dilated cardiomyopathy is classic. Arrhythmia and aortic dissection is also a feared complication as well. The cardiomyopathy we can rule out because he had an echocardiogram and it showed a normal 55 to 65% ejection fraction. Another fact is that ejection fraction is purely subjective. Every single cardiologist has a different thing. There is no unique metric that shows us the ejection fraction. It is purely, oh, it looks okay, it looks fine, or it looks really not good. And that's the theory behind that. But yeah, the biggest thing that is to take away is sympathetic stimulation. That's the biggest thing. So I created a little graphic on cocaine and clot-based physiology. So little well-known things that are things that people don't realize that actually cocaine has studied to increase the rate of atherosclerosis. So we know of atherosclerosis being genetics and being what we feed our bodies and exercise and everything. But really, cocaine is also there to accelerate the rate. So that's a thought process behind that. And this guy had hypertension, hyperlipidemia. He was not supposed to be on his blood pressure medications. So he was kind of a walking heart case in general prior to this. So the theory behind this, cocaine causes coronary vasospasm through adrenergic stimulation, like we said. Then it causes endothelial dysfunction, followed by the release of von Willebrand factor and fibrinogen, which, if you recall, increases platelet aggregation and adherence. And this altogether forms a clot. How it formed such a large clot, we don't know, but that's the theory. So prevention management, in my final conclusion about this, is that echocardiogram remains the gold standard for initial diagnosis of aortic masses. Now, this is really a gray area because recall, we did this second, we didn't do it first, and that it really comes to the judgment of the cardiologist. There really isn't a hard and fast rule in your treatment plan for this person. However, the general rule is you don't want to cause something like this again. So what do? We make sure that he doesn't have any clotting problems anymore. So we put him on Coumadin, per cardiothoracic surgery. We put him on metoprolol, same dose that he's been on. Valsartan, same dose he's been on, just refuses to take it. He's on aspirin and Plavix for life. And then because of his hyperlipidemia, we put him on a statin, 40 milligrams every day. We did, like I said, have a hematology consult was made, but truly, there really wasn't much that we could do at that point. We did counsel him and get and offer rehabilitation resources for his cocaine abuse, but it is very difficult to sway someone with such a very powerful drug. So that was the general consensus of what we did, and it was a pretty interesting study. For this reason, I'm going to open the floor to questions. If I can't answer your question, I have my cardiologist on standby who I can email you guys later at some point, but I'll try my best to answer whatever questions you guys have. So thank you ahead of time.
Thank you, Landon. I really enjoyed hearing your talk and appreciate you bringing that here. And congratulations on, being able to submit this for publication. That's really cool. I think Dr. Johnston, I think I saw your hand up. If you want to go ahead.
Landon, thanks for the presentation. It was excellent. Well done.
Thank you.
Couple general questions. When you looked at the cardiogram and you saw diffuse ST elevation multiple, you said implied more than one lead. What was your thinking when you saw that?
So usually we have, so when you have diffuse ST elevations, that can be, from my studying prior, and correct me if I'm wrong, but sometimes you can think of like a pericarditis kind of deal. You can think of myopathies in general. This was in 2 to 3 leads, if I recall. And my doctor, I had a lot of questions on my cardiologist rotation. And for the most part, to my understanding, it was 2 to 3 leads. It was in the anterior region, mostly on like 2-3 AVF kind of style, maybe a spattering of V1, V2. But it was not a demonstrable classic ST elevation. It was more of like a mild elevation that I probably wouldn't have called it, but that's what he said it was. And he called it non-specific ST elevations. So
right, that's reasonable. Did you have any old tracings to compare with?
I did not, because it was at a different facility. They tried to move him to he's in a mountain town and did only EKGs in his area. I'm sure I could ask my doctor to send them to me, but for the most part, it was at a different facility, and I don't have access to care everywhere here.
Fair enough. After the procedure, was there a change in the cardiogram?
So after the procedure, so that's a good question. I don't recall that there was a demonstrable change. Oh, you know what? He was in normal sinus. He was normal sinus.
Well, that's the rhythm. I'm just asking about the ST segment.
No, he did not have any significant change. Our theory behind what happened was, it's tough. He was a very tough case, but our theory was that he had a ST elevation, a heart attack from a microthrombus that was coming off, that embolized off of this mass, and then went to his right coronary artery or left for some reason, and blocked it temporarily, but somehow dislodged prior to our coronary intervention. As for his EKG rhythm strip, I don't recall looking at it after the fact.
No, that's fine. That's fine. I just, the other thing you'd have to think about, if there's no evolutionary changes on the cardiogram, this is a normal variant for him.
Right.
That's very possible.
And he had a stent. He had a stent prior in 2016. So that stent that has previous ischemic change could also show that similar ST.
It may. That's why it's important. That's why it's important to have an old record to go back on so you can compare it to.
Yes, sir.
Thing was, did he have a murmur?
No, no murmur.
No murmur.
No murmur.
The proximity of the clot in adjacent aortic valve is an unusual thing to not have a murmur.
I know. Believe me, my doctor, after we found that echo, he went straight to his room, and he has a fancy stethoscope that has like the electronic stuff that shows hyper sounds that are in that area.
Yeah.
He put it right to him. He was there for a good minute and a half, didn't hear anything.
Yeah. Last question. Did you culture anything from the clot, or did they even culture the clot.
They did not call through. It was such a quick turnaround time. But I will mention that in the cardiothoracic surgery, they spared the valve. So the valve was normal in nature when they got it out, and they were able to spare the valve. So the idea of infective endocarditis was on our plate, but he did not have a fever. He was asymptomatic otherwise. And so our thoughts were, we're not going to order a ton of stuff on him if he's already.
I got it. I'm just wondering that if this would, if there's only 13 of these cases
I know
reported in the literature, this is a weird one.
Yes.
You just gotta be trying to cover all bases, but
I know.
the chances are you never live to see something like that again, unless you're dealing with an endocarditis or drug addict or somebody like that. But cocaine. What are you gonna do?
Yeah, I
I
remember.
enjoyed it. It was well presented.
Thank you. This is my first day on cardiology, and my doctor was scared of me because this was the bad one for the day one, and he thought I was bad juju.
Yeah.
We had a couple other really hairy cases that I might present in the future. I don't know. I guess I might just be bad luck.
Yeah,
So,
you're gonna get the reputation of being bad luck on cardiology.
I know.
Thank you.
Thank you, Dr. Johnson. Dr. Wolf, I see your hand up. Go ahead, please.
Yeah, thanks. I enjoyed this very much. That was going to be my question, wasn't there a murmur? I would have thought too that there would have had to have been a murmur there. What I was curious about, and I don't know diddly squat about heart valve structure. I was actually trying to look here a little bit, but I was curious whether or not what you saw was due to more of a blister than just erosion of the epithelial cell lining or endothelial cell lining on top of it. I mean, is there any circulation in there? Because it seemed to me that if you just had an epithelial cell sloughing off that needed to be replaced, there's no way in hell that you could really generate enough of a structure to support that. But if in fact that you actually blistered out and you had the fibrotic aspect of the thrombosis allowing you to protect it while it was getting big, that it could survive under those circumstances. Now, I guess arguing against that, though, would be that when they took it away, that the valve seemed normal, but it still seemed to me that you potentially took a divot out of it.
So for one, the cardiothoracic surgeon said it was pedunculated in nature. That was more so connecting to the wall of the aorta rather than the valve itself, which is why they saved it.
Okay.
It was not, on cutting it out, the pathologist ruled it as a thrombus, but I didn't read anywhere in the note that said there was hypervascularity, or if there was any, they said they didn't want to make sure there was any hypervascular or metastasis or cancer in nature. Because you'd expect, you're right, that if it was a growing epithelial papilloma or a fibroblastoma, that it would have its own blood supply. But a sloughing off epithelium, we have no explanation of why he has this massive thrombus with a pedunculated stalk attaching to the aorta. It's quite the marvel. But I would love to hear, you are really good as well at physiology and biochemistry and stuff. So if you have any thoughts, I'd love to hear them, because I could probably relay it onto my doctor as well.
He's just real lucky that it was pedunculated and attached.
Yes.
Otherwise, that clot would have been gone north or south big time.
Big time.
And the school would have been over. The fact that it stayed put, he was lucky.
Very.
Student Dr. Vayner, I see your hands up. Go ahead, please.
Okay, can you hear me fine?
Yep.
All right, great. First off, Landon, that was a great presentation. I found it really interesting. So my question is, given the rarity of this sort of thrombus in the aortic valve, with this patient, if he were to continue using cocaine and not adhering to his medical regimen, how likely would you say this could happen again to him? Or do you think this probably will never happen again in his case?
Could you repeat that last sentence? I
Yeah.
heard everything except for that last sentence.
I couldn't hear a word. I couldn't hear a word of it. Could you repeat the
So
whole?
I think what I got was that, if this patient continued with the cocaine use after this treatment, what would be the likeliness of this happening again? Is that, Phil, did I repeat that correctly, that last part?
Yeah, yeah. If
Okay.
he continues to use cocaine and if he continues to ignore part of or all of his medical regimen, how likely would this possibly occur again to him, given how rare it is as a whole?
So, okay, so to answer your question, it's tough because we lost him to follow-up, so we don't know if he has a hypercoagulable state in nature. He's 48 years old, so he lived a majority of his life on nasal cocaine that he has used, so who knows if it has any recollection of it. It could just be one of those things, kind of like similar to cancer, how it only needs one bad egg to ruin the whole carton. Similar in nature. I think that if he continued his cocaine abuse prior to and didn't come in for help, or he just it probably could have gotten bigger. The general vasoconstrictiveness of it would also lead to more endothelial dysfunction and endothelial sloughing, and so it probably could have gotten bigger. And who knows if that pedunculated stalk could have saved as large of one as we saw.
So, student Dr. Riggs, I think some of it too is if he continued with the medication regimen that he was given following treatment, would that have any impact? Student Dr. Vayner, did I catch that right? I heard you say something about if he continued his the medication treatment and regimen, would that also have an impact as well if he continued with the cocaine use?
Does this include? Oh, in addition to the cocaine, so if he continued to use cocaine along with the medication regimen, right? Is that what I'm getting?
No, I'm sorry. I guess my mic was really bad. Can you guys hear me now pretty well?
There's a pretty bad echo. That's what's distorting things, is there's an echo that's causing us to kind of lose the clarity.
Got it. Well,
If you want to put it in the chat, I'd be happy to read it from there, because I actually have a question and then we can come back to it for sure.
Yeah.
Sometimes, Phil, if you have a headset, that might alleviate some of that echo.
But student Dr. Riggs, I was wondering about, so the stent placement. So I am sort of familiar with that process, and it brings to mind a situation where following someone getting a stent put in, it actually kind of caused some stuff to become dislodged. They end up with some blood clots in their lungs that ultimately have to be cleared and passed. So how common is it when you're putting those stents in for something like the plaque in this case to kind of get knocked loose and travel places you don't want to? And then I guess in addition to that, is it possible for plaque to continue to grow over that mesh stent after it's been put in?
So, okay, quick answer to your second one. Most stents nowadays are drug-eluting stents. So they release Plavix along with other fancy drug names that are antiplatelet and antiplatelet aggregation stuff called P2Y12 inhibitors. And those are acting to reduce anything forming on top of those for thrombus formation. As for atherosclerosis forming over top of that, yeah, it is possible, but and some people have worse luck. African Americans unfortunately have the highest rates of hypercholesterolemia and atherosclerosis. So it is possible, and drug-eluting stents do last. I forget the metric. It lasts a while, but it's not permanently drug-eluting. So the idea is medical management for that. As for the question you had, the first question, so I actually asked the same question to my doctor too. So it is theoretically rare, if not impossible, for that to happen in a left heart cath. So if you were to dislodge if we're looking at our heart, and our heart has a bunch of arteries that are coming off the main trunk and they're pushing outwards into the heart, and the heart itself is sucking up all that blood, and it keeps on doing it over and over again. If we were to cut out that clot, the clot would only move farther towards the heart and then kind of get stuck there again. So theoretically, it is very, very rare. We can suck out clots through a catheter to suck it out and then pull it out, and that might cause it to dislodge, go back into the pulmonary artery system. But the highest thing for blood clot in the lung specifically would mean it have to come from the right heart. So the right heart goes to the pulmonary arteries, and the pulmonary arteries go straight to the lungs, and that's what gets caught in our lungs. This is why when we have a blood clot in our leg called the DVT, this is the most feared complication, because the first spot it's going to go is to your lungs, because it goes up the veins to your right side of the heart into the lungs, and then you have a blood clot in your lung. So that's the idea. It is rare, and my doctor said it is extremely rare and unlikely, but it's more, he guessed that someone that had a blood clot would probably only come from the right side of the heart.
Okay, thank you for that. Dr. Wolf, I see your hand went back up. Go ahead, please.
I was going to say, Phil was, if he's prepared, could go ahead first.
Yeah, you guys should probably hear me better now.
Yes.
Yes.
Yeah.
Yes.
Yeah. Okay. I couldn't find my AirPods, and then as soon as I realized I really need to find them, I found them instantly. Funny how that happened. So for the most part, you did answer my question, but I'll just restate it in case there's anything you want to add. So first off, my understanding is that they removed the clots when the cardiac thoracic surgeon went in.
Yes.
Yeah, they pulled that all out.
All gone.
Okay.
It's flushed out
So,
to make sure nothing's there. Yes.
right. And okay, so given how rare this case was, let's say the patient now goes back to not taking his prescribed medications and continues his daily cocaine use. Do you think there's a fair enough chance that he could develop another clot in that aortic valve, as opposed to just a different heart complication, probably getting there first?
Well, yes, because cardiothoracic surgery in itself is a trauma, and a trauma to your heart valve there or your aortic valve there, along with suturing, means it's a perfect nidus in an area. Remember, we have thrombus forms on places that are already pre-worn. So we have a pre-worn area. We are more likely to have something stick on there because it's not smooth. It's like you're trying to grab onto a rock climbing versus a flat wall. It's just, you're going to be able to grab onto the rock. So yes, in theory, it could happen. As for if he's not taking his medication, the cocaine, yeah, cocaine mechanism, endothelial dysfunction, causing the platelet aggregation and release of fibrinogen and all that stuff, yes, 100%. So could it happen there? Yes. But then again, as devil's advocate, it's high pressure there. It's super high pressure. And this guy had hypertension. So he has a ton of, like, he had 171 over 111 on presentation. And you're telling me that pedunculated stalk did not break off? It's very hard to wrap my head around, but my honest question would be maybe. I wish I had a better answer.
Thank you. Thank you.
So my question was actually kind of along those same lines. And so I was sitting there and trying to go through my mind's eye again of what could potentially cause something like that. And it seems to me that when you're adding cocaine into that mix now, you're going to sit there and you're going to potentially constrict your more tertiary. I mean, so these people are going to spike that blood pressure up from where it's at. And so I'm wondering if you had the possibility that he had an aneurysm, and you know, repeated stress to that aneurysm kind of blew it out, but it never ruptured, you know. So all of a sudden you had your Virchow's triad or whatever the hell that's called, where you've got an area of stagnant blood now that would potentially accumulate, and you would have fibrosis, but you would still have now that kind of protective. I mean, you presumably had some fibrous structure around it to protect it originally while it was forming. Because I can't get, you know, my hard part for all of that is getting to the point where it doesn't get washed away. Or, you know, I guess if it's pedunculated, you know, if you know, it could roll out of the side or whatever, but how could it get there where you could get that big ball forming without it being, you know, sheared off by the blood going past? So I'm sitting there thinking it had to start somehow. It had to be, you know, back to my original blister thing, that it had to somehow balloon out and develop from a blister in order to be able to survive, is the only thing that works in my little mind's eye, at least.
Yeah, that's a really good observation, and I think that's your guess is probably as good as mine. As for the aneurysmal flow, you mean like an aortic aneurysm, right? In the aorta there?
Yeah, yeah. I
Yeah.
mean, well, I mean, if it's in the wall there, you got blood vessels there, and
Yeah.
and you could have, and you got your, I mean, your a secondary, or right before you get to your arterioles, you could have an aneurysm there potentially where you've got a muscular wall, you've got some adventitia, and you constrict downstream of that, and all of a sudden you're bringing your pressure, further upstream, by virtue of that, and that you could conceivably blow out an area, and so yes, you're shutting off blood flow downstream as a consequence of that potentially, but you won't necessarily see it because you got some degree of collateral circulation.
Yeah, yeah, and so for one, we knew there was no aneurysmal flow because the echocardiogram showed that the aorta was normal in size and length, and so we looked at that. So it was not aneurysmal in nature. We can usually see a ballooning, and that's why we do. That's the same reason why those that are 65 plus get a abdominal aneurysm check, because we do an echo to check that out. So on the echocardiogram, part of it is looking at the aortic valve as well as the aorta itself. And it was normal in structure. Aneurysmal flow, he did say that during the intraoperative period of when we were doing the Cath Lab, he mentioned that it was slow flow and that his call was aneurysmal flow of the blood in the area. But he said that's normal with those who take cocaine and drug abuse. So your guess is as good as mine. He is still back.
Yeah, I was just gonna say, I probably don't know enough words to describe what I was trying to say, but I was not thinking aortic aneurysm at the level of the aorta, or I guess the capillary aneurysm or microaneurysm at the level of the capillary. I was thinking at an aneurysm in the blood vessels inside of the aorta as a potential cause for it, and that when you give something like cocaine, or I mean, when you're going to constrict, we teach you how it's your tertiary arteriole. I mean, it's your arterioles rather than the small arteries that are going to see the biggest increase in resistance. So when you increase that resistance, the pressure is actually going to be higher upstream from that. Right. Because the blood didn't go through. And so I'm going, okay, so you clamp off the smallest blood vessels, and now you got, it's woof, right above that, and that has a wall that could conceivably contain, that you're not going to have a micro bleed, but it would provide a structure then in which you could have static blood that would continue to be fed, because there's a tube going into it,
right?
And eventually that might be plugged off or whatever. But during the early stages, there's something trying to blow up that balloon, and the blood is stasis or static, just like it. Fibrillating heart will have the appendage. There's nothing going on there, so blood can accumulate there. So I was just thinking I guess along those lines. That's what my mind's eye came up with on this one. But again, it's all imagination.
I'm gonna look at this that up and let my cardiologist know, because I'm sure he would like to hear that thought process too, because he has no other explanation either.
It's another hypothesis, so I think it's worth it. So thank you, Dr. Wolf, for bringing that up. Thank you again, student Dr. Riggs, for bringing this to us, and congratulations on your publication. And, thank you. If you want to come back with any other strange cases, you know where to find us, and we'll be happy to give you that platform. So everybody have a nice weekend. Thank you for coming.